Okay, so welcome to ECG lesson 3. Thank you for joining in. You've got all the slides that are available there, and then the ECGs for Coot at the end. So I'm Dr. Sanderlands. Most of you will have met me or will be meeting me during the course of the medicine block. So again, we just have to go through and thanks for joining in. Just remember that the ECG is quite a highly difficult skill to become a master, and I'm trying to help you bridge the gap between being, a beginner and to trying being competent, really knowing what the main ECGs show, the common ECGs, and really to be able to answer these in an exam situation. And of course, you're going to develop more experience as you go through the clinical years. So you're going to learn at different paces, certainly looking at more ECGs and then looking to see the patterns certainly improves things. For any of you that learn a musical instrument, putting in the hours of practice will help, along with everything else. And the balance of work life and rest and play is important. So sometimes it does help to have context to some of these ECGs. If you're in clinical years, I've sometimes done these lectures for preclinical students. So sometimes the context is helpful. Okay, so this evening we're going to look at ST changes and T-wave changes. So really, what does this mean? It means STEMIs, acute coronary syndromes, and structural heart disease. We need to know about the regions, especially for acute coronary syndromes, and link them back to the coronary anatomy. We need to know about reciprocal changes, and what does that mean? I want to be able to improve your confidence at ECG interpretation. So this is just another session there. So we'll go through the pertinent ECG signals for STT wave changes. Why does it change? A little bit of the physiology, but really it's not something you'll be tested on, but just to understand why you get ST depression, ST elevation, and T wave inversion. We'll look at some pathophysiology. We'll look at the regions of the 12-lead ECG and try to link that to coronaries, because ST changes normally group in certain regions, and that's probably linked, it is linked to the coronary arteries if it's an acute coronary syndrome ECG. We'll go through lots of examples of 12 leads to go through with my algorithm, and then we'll end with some Kahoot. So hopefully it shouldn't be as long as last week. We'll try and get through things as quickly as possible. But my main aim is to make sure that you understand everything. And if there's any questions at any time, try and use the chat. I'll keep on top of it, or please ask any questions. So we've shown this ECG, sorry, someone wants to be admitted. We've looked at this before. So generally you're looking at 10 leads, amazingly giving you a 12-lead ECG. Your right leg is your reference, and you're able to generate 6 leads by the comparison of the right arm, left leg with the right leg, and the 6 chest leads that go on the front of the chest. Don't forget though, you can put more leads around the back of the chest. So carrying on from V6, you can put 7, 8, 9, which are visualizing the posterior wall. So ECGs will be numbered differently with V7, 8, and 9 if there is a posterior ECG. We'll show you some examples later on. So I've talked to you about this before, about Einthoven's triangle, looking at the ratios between the right arm, left leg, and how we generate the limb leads, and using the limb leads to try and look at the axis of the heart. So again, recapping, when we ever look at our ECGs, we are looking at the sinus node triggering things off, and that is atrial depolarization, and that is shown by the P wave, which generates contraction of the atria. Then we have depolarization into the AV node, going into the AV node, which will be your PR segment. Then we have depolarization via the right bundle and via the left bundle. Don't forget that the left bundle does split into 2 with an anterior fascicle and a posterior fascicle. But for the means of this diagram to show you, we've got the right and the left bundle. So that is QRS depolarization. And normally our QRS will be less than 3 small squares. At the same time, really as the depolarization occurs, we will have repolarization, which is measured from the Q to the end of the T wave. Okay, and the Q to interval will be roughly 2 large squares for a heart rate of about 60 beats a minute. So how do we generate a QRS signal? We've gone through this before, just so you're aware. So if the wave of depolarization is going towards a recorded lead, then we're going to have a greatly positive deflection. If it's going mostly towards the lead, a less positive deflection. If it's perpendicular, 90 degrees to the recording lead, we would have a biphasic response so that the plus and the minus are small, but they equal each other out. Again, the wave depolarization going away from the lead, it will be negative, and then completely away from the lead will be the most negative lead. So this is for the QRS. This is for depolarization. The important thing that we need to do with STT wave changes is try to think in 3 dimensions. And then I'll show you again later on that we'll try and overlay a map of the coronary arteries. But just to recap for you, have to remember that the anterior wall of the heart is made up of the V1 to V4, okay? And that might be your left anterior descending artery, anteroseptal region. The posterior wall, as I've mentioned already, is made up of V7, 8, and 9, which are put onto the back below the left scapula. Now remember, your surrogate leads for this, so you haven't done an ECG, if you haven't done an ECG with V7, 8, and 9, you might see changes in V1, V2, V3. And have a think about what changes you would see. You might actually see ST depression in V1 to V3, which is your reciprocal change for the back of the heart, V7, 8, and 9. So if you see V1, V2, V3 showing ST depression, make sure you do an ECG that is V7, 8, and 9 to make sure you do not miss a posterior STEMI, which is the circumflex artery. Okay. The lateral wall is made up of V5, V6, 1, and AVL. And again, could be the circumflex artery, depending how it comes down around the heart and around the lateral wall. It could be part of the left anterior descending and early branches of the left anterior descending, such as the first diagonal. The inferior wall is made up of 2, 3, and AVF. And I put over here the V4R is a particular ECG, which is on the right side of the chest, opposite where V4R is on the left side of the chest. But it's quite highly predicts a proximal right coronary artery lesion that comes around this way, a proximal right coronary artery lesion, which can be important in patients presenting with an inferior STEMI, because they invariably, their blood pressure may be low, and sometimes they actually need IV fluids whilst they're waiting to have their right coronary artery opened up with PCI. And then lastly, AVR. Remember, AVR is at the top right. Mostly everything beneath AVR, it's showing negative, so it's going away. But sometimes you have to think if there is ST elevation in AVR, that might be a reciprocal change of what's going on around the heart here. So it's still important lead to look at when we've got STT wave changes. Okay, so what are the changes? So having seen some of you do the simulation, and you've all done it very well, we just have to be looking at the ECG in terms of the ST segment. What does that mean? So we've got our isoelectric line, remember? And in a normal ECG, the ST segment here is actually at the line. You draw a line, if you draw this line in continuation, you will see that there is the ST segment being normal at the isoelectric line, okay? So let's move down to STEMI first. So when we're looking at ST elevation, you have to clearly see that the ST segment is above the isoelectric line, okay? So the isoelectric line carries on here, goes along here, so the ST segment is definitely above the isoelectric line. When we have ST depression, you've got to think that the isoelectric line carries on here. The ST segment is now pulled down below the isoelectric line, meaning that there is ST depression. And then lastly, the ST segment here, it is at the isoelectric line, but the T wave is inverted. T wave is inverted. Okay, so remember that the ST segment is being normal is at the isoelectric line. Above the isoelectric line, it's ST elevation. And again, remember, it's going to be grouped according to the coronary artery. And with ST elevation, this is the trump issue. This is in charge of everything. So a STEMI overrules a non-STEMI. So you can't have a STEMI and a non-STEMI. So you have a STEMI, and then on the opposite side of the affected coronary artery, you will have ST segment depression or T-wave inversion. That is your reciprocal change. But it's not the same the other way around. If you have a non-STEMI with ST depression, you will not get ST elevation in the other leads. That's impossible. Okay, so ST depression on its own would be a non-STEMI. T-wave inversion on its own in a region would be a non-STEMI. You do not get reciprocal ST elevation. So that means ST elevation is our trump. That is the most important thing. You can't beat ST elevation, but you can get reciprocal changes with ST elevation of either ST depression or T-wave inversion. Any questions about that? Okay. So let's just move on to a little bit of the physiology. Why do we see ST depression, or why do we see ST elevation? So it all has to do with how the ECG is recorded. Okay, so let's have a look at ST depression. So we've got non-STEMIs are normally caused by subendocardial ischemia. So this is the area of ischemia. In the resting state, the wave of depolarization now is, even in the resting state, because of the ischemia, is going towards the recorded lead. So in the initial depolarization of the QRS, the recorded lead here is recording a positive segment. So it's above 0 at the isoelectric line. That's the start. We then get depolarization of the whole of the muscle. So at that point, the recorded lead is not seeing any signal. Okay? So there's a 0 recording at that point in time after the R wave. So this is now recorded at 0 on the ECG. And then we have repolarization. That repolarization of the muscle, again, is going towards the recorded lead and will be above, which is positive, above the isoelectric line at 0. So really, it's just because the leads are starting off positive and ending positive that the ST segment looks depressed, because then this ECG will be portrayed, this will be the isoelectric line, and therefore the ST segment is reduced. Here's our isoelectric line here, our ST segment is reduced. Okay, so you're not going to be tested on this, it's just a bit of knowledge just to try and find out. In the same way, ST elevation is the opposite. So in our resting state, we have a full thickness infarct, okay, full thickness of the muscle. The blood flow is completely occluded to the area of muscle. The wave of depolarization is going away from the recording lead. So in our initial QRS, our line is starting below 0, okay? Then we have our R wave and the rest of the depolarization. Again, with depolarization in this example, there is no recording, there is 0 recording at the recording lead here, and our depolarization is being shown at 0 at the isoelectric line. And similarly on repolarization, it's going away from the recording lead, it's negative, so it'll be below the isoelectric line. However, we put all this now becomes our isoelectric line on the recorded ECG, and so we see therefore ST elevation in this example. Okay. So what actually happens? Let's have a look at, think about the pathophysiology of ST elevation. So really you've got to think about the artery. In ST elevation, this is a cross-section of a coronary artery where the artery is completely occluded. There is no blood flow down the coronary artery. Okay, so the plaque has ruptured, there's a thrombosis inside, and there is no blood flow. So chest pain and ST elevation on the ECG, that is the trump card. Okay, with ST elevation, you will get reciprocal changes, either T-wave inversion on the opposite side of the heart or ST depression on the opposite side of the heart. Alternatively, we have a non-STEMI or a no ST elevation MI, where there is some reduction in blood flow, but there is just enough blood flow that it's not totally ischemic or totally occluded. And so the ECG will either show T-wave inversion or ST depression, or it could be a normal ECG if some of the ischemia has resolved. There will not be reciprocal changes for a non-STEMI, i.e. there's not ST elevation on the other side of the heart if there's ST depression on one wall, okay? So that's the difference between a non-STEMI and a STEMI. So what happens now with T-wave inversion? So again, this is just something that you need to you don't need to know or will be tested on, but just to try and understand why. So you've got to think about the opposite, slightly opposite effect from the QRS. Now, normally in the heart, the sub-epicardial layer will repolarize first, rather than the subendocardial layer in the normal situation. So if it repolarizes first, it repolarizes away from the recording lead. This is repolarization, therefore, the lead will be positive. So that's in the normal. In this example, we're looking at ischemia in the subendocardial layer. So there's no blood getting to the subendocardium. That is a non-STEMI. Therefore, the subendocardium will therefore repolarize first before the subepicardial layer. And because the wave of repolarization now will be going towards the recorded lead, there will be a negative T wave. Okay, so normally the T wave should be positive, because in the normal situation, the epicardium repolarizes first before the subendocardium, but this is in ischemia, where the opposite occurs. Repolarization goes towards the recording lead because the subendocardium is ischemic and repolarizes first. The T wave becomes inverted. Okay, so the other thing that we're looking for on the chest leads, we're not only looking at ST elevation, we are trying to look to see sometimes in ECGs that there may have been an old infarct or a previous infarct. So one of the ways that we can look at that is to look at something called the R wave progression on the chest wall. I've talked to you about this before. So you have to think about the wave depolarization going from the top here into the heart. You have to think in 3 dimensions. This is like a CT scan, and the patient's lying down. The wave depolarization sort of goes across this way, down the ventricle to the apex, going inwards. And so when we start off at V1, there is a little R wave, which you'd expect, and this is variable on different people, but mostly negative deflection. The R wave starts to get bigger, and there's still a big S wave. Then we have something called the transition complex, where the R wave equals the S wave. Okay, so the positivity equals the negativity. This is the transition, which should be at V3. And then definitely V4, V5, V6 in a normal heart should all be positive. Okay, so what are we looking for if it's not? What do we look for if there are signs of a previous infarct? So you should know that there should be Q waves, perhaps. There may be poor R wave progression across the chest. So the R wave doesn't get bigger as you go to V6. But also you're probably likely to see T wave inversion as a sign of a previous subendocardial infarct. So this is an example for you, which I've shown you before. So we're looking at the chest leads here. We're looking at the chest leads. So if we go through our routine basic algorithm of the ECG, you would probably get to the fact that, you know, the R wave, we're looking at the QRS next. Oh, sorry. We're looking at the QRS. And so we got no R wave. Yeah, we got a narrow QRS, no R wave. Oh, no R wave in V3. Oh gosh, no R wave in V4. It doesn't come till V5. That's late. So that's what we call late R wave progression or poor R wave progression. In association with this, we do have T wave inversion. So there is T wave inversion across the anteroseptal leads and even laterally as well, although there are no Q waves here. This is probably a large infarct or large anteroseptal or anterolateral infarct for this patient. So it's evidenced by the Q waves, the poor R wave progression, and the T wave changes across the chest leads. Where else can this happen? So in patients with left ventricular hypertrophy, if the leads have been inaccurately placed, patients with a dilated cardiomyopathy, but also it can be a normal variant. So we don't sort of tend to worry about it in most patients, especially if the T waves are okay. So it can be normal variant. Okay, sorry. So this is going to play now. So the other thing is we're looking at is for Q waves. And again, most of the Q waves should be in a region of a coronary artery in the same way that there would be ST elevation. If the myocardial infarction was untreated, then obviously then the muscle would be damaged and would be showing signs of a Q wave. So what we expect is a negative deflection that's greater than 40 milliseconds and at least greater than 25% of the whole R wave. So I'll just let this play again. So this is where lead 1 would be. We'd expect lead 1 to be here. There's an infarct in this lateral region. So we've got a Q wave. It's bigger than 1 small square. It is at least 25% of the R wave. Okay. So that's a Q wave. Again, remember these are going to be grouped. So a lateral wall infarct, if it was in one, you'd expect it to be an AVL. It might be in V5, V6. If it was an inferior Q wave or an old inferior infarct, you'd expect it to be in leads 2, 3, and AVF. So these Q waves group together in a similar way that these Q waves group together in this anteroseptal region to signify the area of muscle that is infarcted. The other things that we're looking for as well, so it's not just STT wave changes that are signifying acute coronary syndrome. There may also be signs of large muscle mass. So if there is a large muscle mass, we talked about in the first lecture about there being a very tall R wave. And so in this example, V5 is very tall. This ECG is recorded correctly, but there is a very deep S wave in V4 and a very tall R wave in V5. So it actually approaches and goes into V4 there, okay? So that's obviously not normal. That means there's a very, very big R wave here and a very deep S wave in V1. So those two put together, meaning if they're over 7 large squares tall, plus down there, and obviously you have left ventricular hypertrophy. So when there's left ventricular hypertrophy, there is a big muscle mass. With the big muscle mass, we get abnormal repolarization, which can be identified by the negative T wave. So in this example, it is inferior lateral T wave inversion. Okay, now because there is a tall R wave, the most likely cause for this T wave inversion is hypertrophy. Now, how can a muscle hypertrophy? So a muscle might hypertrophy because of aortic stenosis. The valve is very tight, the muscle has to squeeze harder. It could also hypertrophy when there is high blood pressure and you get concentric hypertrophy for both aortic stenosis and high blood pressure. So the heart has to work consistently harder. There is also a cardiomyopathy that's fairly common in 1 in 500 individuals in the population called hypertrophic cardiomyopathy. And that's more where there is septal hypertrophy, so where the septum is or where the apex is. So remember, T wave inversion on an ECG may be signs of an ischemia, but in this example, the R wave is very tall, so it's much more likely to be associated with hypertrophy. And we call this left ventricular hypertrophy with abnormal repolarization. So just to mention about the QT interval, I don't think we'd ever ask you to measure it, but I've talked to you about this before. So to recap, we use lead 2 or V5 normally because they're normally positive T waves in these leads. The preceding, so the heart rate, remember, will change your QTC. Sorry, the heart rate will change your QT over the calculation of the square root of RR to really give you the QTC that is roughly the same. So if the heart is slow, the R interval is long, the QT interval will be longer. But when we put it into the equation, the QTC will be roughly the same. When the heart is faster, the RR interval is shorter, so therefore the QT interval will be shorter when the heart is faster. But it all measures out in this equation for corrected QT interval of the heart rate being roughly the same. And it is the T wave that we use, so we teach the tangent. So you don't add the U wave into this at all because it will make it too long. And so we're expecting a value of around 2 large squares for a heart rate of around 60 beats a minute. So 2 large squares in a normal individual, just so you're aware. So it can be abnormal in certain situations. So in MI, myocardial infarction or ischemia, the QT interval can be prolonged. Where there are instances, again, of abnormal repolarization, such as structural heart disease, left ventricular hypertrophy. Obviously, where there is prolonged QRS already, you'd expect to measure the QT interval to also be prolonged, such as left and right bundle branch block. So specifically, the QT interval can be prolonged where there is hypo or low levels of potassium, magnesium, and calcium. Actually, very interesting, in diabetic ketoacidosis, you can see a prolonged QT interval, which will correct, obviously, with treatment. And lastly, probably class 3 drugs are most important. Some antidepressants as well will prolong the QT interval. So those sort of patients will need ECGs at regular intervals to keep an eye on, especially with any dose changes. A reduction in the QT interval can be seen with hypercalcemia. Okay, any questions so far? Of course, yeah. Okay, so when you're looking at ECGs, you go through your basic algorithm. In this example, you're probably going to end up saying, yes, the QRS is narrow, but you can see the QRS is sort of bridging other areas of the ECG. So certainly a tall R wave, a very deep S wave here. And so the calculation of this is like 1, 2, 3, 4, 5, 35, 38 millimeters down, plus 1, 2, 3, 4, 5, 6, 30, 33. So you're looking at something like 70 millimeters, over 70 millimeters height of the V1 S wave added to the V5 R wave, and that's clearly left ventricular hypertrophy. This is an ECG that's recorded correctly. On top of that, you have the T wave inversion. So if you didn't have left ventricular hypertrophy, the T wave inversion could be a sign of a non-STEMI, or if there's clinical context that they've had chest pain in the past, it could be a sign of a previous heart attack, although there are no Q waves. So the other thing it could be is another form of structural heart disease. But in this example, this could be left ventricular hypertrophy with repolarization because of the T wave, as evidenced by the tall R wave in V5 and the deep S wave in V1. Okay. Any other questions at all? So remember your basic algorithm, make sure if you're not sure what you're seeing, go through the rate. Obviously make sure the ECG is recorded correctly and is from the right patient that you've seen. You then look at the rhythm. So is the rhythm regular, sinus arrhythmia, irregular? The simple way that I look at the axis is to look at the most positive lead of the limb leads, and AVL being the most positive, you have left axis deviation. Lead 3 being the most positive, then you have right axis deviation. We then move to the intervals, the PR interval, 3 small squares, up to 5 small squares. If the PR interval is short, look for a delta wave, and therefore Wolff-Parkinson White. The QRS being up to 3 small squares wide. If it is broad, then think of bundle branch block. If the R wave is very tall, then consider left ventricular hypertrophy. The other place to look at is lead 1 and AVL if the R wave is tall. We talked about the QTC being roughly 2 large squares. And then lastly, what we're concentrating on this evening are any STT wave changes. Okay, so remember now, we talked about things being grouped together. So if you have ST elevation in lead 2, you're going to expect it in 3 and AVF, okay? In the majority, 99.9% of cases. So if you've got 2, 3 and AVF as ST elevation, you have an inferior STEMI. If you have an inferior STEMI, for example, your right coronary artery is going to be most affected 80% of the time. 20% of the time, it's going to be the left circumflex. Okay? So if you have inferior ST elevation, you need to look at the lateral leads, or the anterior leads are going to show reciprocal changes. What I mean by that is they might show ST depression, or they might show T wave inversion. So that tells us we've got an acute STEMI, okay, with reciprocal changes on the other side. In the same way, if we have anterior septal ST elevation, so anterior septal leads, we're looking at V1 to V4, okay, S elevation, we're going to think about the left anterior descending. And if there is anterior S elevation, then we're going to expect inferior, most likely, ST depression or T wave inversion in the acute situation. Again, the same for the lateral leads, which are signified by 1 and AVL. So you have a change in ST elevation in lead 1, you'd expect it in AVL. It may also be in V5 and V6. So it's grouped together. These are the lateral leads. And so it's going to be the left circumflexes most likely, or it could be a diagonal branch of the LAD. Any questions about that? So not forgetting again that if you have ST depression in the anterior leads only, I'll show you an example. Remember to do a posterior lead V7, 8, and 9. So again, we've got to think about things in 3 dimensions and sort of overlay that with the ECG at the same time. We're trying to think about, look at the arteries, where they're traveling and what they are supplying. So remember, just to recap, your left main coronary artery splits into the left anterior descending down the front of the heart. The anterior descending branch supplies the anterior wall of the left ventricle in most patients, the front 2/3 of the septum, including the bundle branches. So that's interesting. Patients that may present with a STEMI, it may just be, their ECG may show signs of just left bundle branch block. I'll show you an example of that. The left main also splits into the circumflex that goes down the back of the heart. The circumflex branch supplies the posterior wall, but this varies in people, the high lateral wall of the left ventricle. And then lastly, the right coronary artery comes down. It gives off a right atrial branch and a right ventricular branch. So that's why the proximal right coronary artery, by looking at V4R being elevated, may explain why patients have low blood pressure, because the right ventricular branch is affected, but does respond to IV fluids. So the right coronary artery supplies the inferior wall of the left ventricle in most people, the right ventricle, the right atrium, and also the SA and AV nodes. So sometimes you can get heart block during patients having infarcts, and sometimes opening up the artery can improve that blood flow, and they don't need a pacemaker. So, yeah, don't scream. Just take your time when you get any help, when you get given any ECG by anybody. Just take your time looking at the ECG. Try to go through the basic algorithm if you can't see any obvious changes. So in the exam situation, you would be asked to describe the abnormalities of an ECG, and then what is the ECG diagnosis. So we'll go through that. I try to do that every time I go through an ECG with you. Make sure you know your territories for ischemia as we've gone through. So we've talked about these already. Superior, okay, or lateral is the same thing, one and AVL. So that's pretty much the same thing as before. Is this infarct or is this ischemia? So we're trying to look at ST elevation versus ST depression and T-wave inversion. And lastly, think about reciprocal changes. Is this a reciprocal change? Certainly in the context of STEMI. Okay. So for this one, the algorithm we have to think about is not really a stepwise approach, but really you're looking at, I mean, it could be a stepwise approach. It depends how you use it. So the first thing we're looking at is there T-wave inversion? Is there T-wave inversion? So let's see. If you have T-wave inversion in a single lead AVR or lead 3 or leads V1 and V2, it's highly likely to be a normal variant. In fact, sometimes inferior T-wave inversion can be a normal variant. Okay, but it may not be in the context that they've had chest pain or having chest pain. Okay, so remember, some T-wave inversion is normal. Next, the T-wave inversion could be regional. It could be V1 to V4. It could be 2, 3 and AVF. Okay, so that might signify a problem with a non-STEMI if the patient has ongoing chest pain, or they've had previous chest pain and they're pain-free. It could be a sign of a previous myocardial infarction, or depending how they're presenting, myocarditis, or even a cardiomyopathy, where then you have to consider also a tall R wave for left ventricular hypertrophy. And lastly, a common cause for T-wave inversion is hypokalemia. Okay, so all these things really, you need to have clinical context to identify why is this regional. And again, also you may have Q waves that are associated with T-wave inversion to suggest that this is a previous myocardial infarction. On the other side, we have ST changes. So if you identified ST changes, is this ST elevation or is this ST depression? If it's ST depression, then certainly we're looking at possible reciprocal changes if there is also ST elevation. However, ST depression on its own will definitely be in more than 2 leads, and again will be regional to a coronary anatomy, but also regional to a structural heart disease. So remember, in V1 to V3, just ST depression could signify an anterior non-STEMI, but make sure you check V7, 8, and 9 that you don't miss a posterior STEMI. ST depression could be a sign of a non-STEMI if it's regional or structural heart disease. Again, consider a tall R wave if you're thinking about left ventricular hypertrophy in addition to ST depression. Again, it could be myocarditis, hypoxia, anemia, or hypertension. we thought these were the main causes of ST depression. It's not an exhaustive list, but the main causes you would see. And then finally, which probably causes, which is very important, is ST elevation. So we can see very minor ST elevation of less than 1 millimeter, and you consider the patient to be young, slim. It may be related to their race or whether they're an athlete. So you can get very, very minor ST elevation, okay, or what we call early repolarization. I will show you an example. You can get isolated ST elevation in AVR, so you need to consider whether this is left main stem ischemia. There may be changes on the rest of the ECG to suggest that as well, but isolated ST elevation in AVR, think carefully about left main ischemia. ST elevation could be in most leads. It could be saddle shape. There's a very particular shape of the ST segment. There may be PR depression, but it's not mandatory to make a diagnosis of pericarditis. And clearly there'll be clinical history that is much more different type of chest pain without there having to be necessarily cardiac risk factors. And then perhaps most importantly, ST elevation of greater than 1 millimeter. So we're trying to make a difference between this minor ST elevation without probably chest pain versus significant ST elevation of greater than 1 millimeter in 2 adjacent leads of a STEMI and reciprocal changes. So V1 to V4 would be anterior, T3 and AVF inferior, 1 AVL, V5, V6 lateral, and V7, 8, and 9 posterior. Any questions about that at all? When you calculate the tall R wave for LVH, is only V1 and V5. No, you can use 1 AVL. So if lead AVL is greater than 12.5 tall R wave, then you've probably got left ventricular hypertrophy on its own. And you've got to be careful about that because you might get left axis deviation with left ventricular hypertrophy. The second thing is if you want to calculate the R wave in lead 1 and AVL together, it's going to be greater than 25 or 5 large squares. So that's an alternative way of looking at. Some people look at the S wave in V1 to V3, although that's not specific, but I use either the calculation of lead 1 and lead AVL being in addition to each other 25 large squares or 25 millimeters, or V1 and V5 being greater than 35 millimeters. Why would there be ST elevation in lead 1 for a lateral STEMI? Okay, so lead 1 and AVL, again, you're not going to get lead 1 being ST elevation on its own. Lead 1 and AVL being ST elevation would be highly suggestive of a lateral STEMI, but in actual fact, it probably is going to be the diagonal branch of the left anterior descending to just get both of those showing ST elevation on its own. Okay, so in answer to that question as well, if we go right back here, remember your lateral wall is made up of AVL, 1, V5, and V6. Okay, this is in most patients. Remember, most patients, when some patients come in with ST elevation, some of them can have ST elevation inferiorly, and it can actually be the LAD that's going right around. So that individual has a very big LAD wrapping right around. It's a distal LAD infarct, but it wraps around the inferior wall, and they have inferior ST elevation. But that's rare. Don't come across that much. Okay, sorry, I was getting confused between lead 1 and V1. Okay, I hope I've answered the question. So V1 would be anterior, remember, V1 anterior, or if there's ST depression in V1, it could be, and V2 and V3, it could be posterior, V7, 8, and 9. Yeah, great, good stuff, excellent. So let's just go back to okay, so let's go through some examples. I'll give you a little bit of time to look at them, and then I'll give you all the answers. I think there's about 12, I think, ECGs. So have a look at this one, please. Okay, so if you go through your basic algorithm, you might come up with some things that may be abnormal, or you've looked at, as apart from the smudge there. So in this example, if you go through everything, okay, all these ECGs are STT wave changes, so you can try and, home in on those. So if you look here, you've got T-wave inversion in lead 3. So on its own, that's going to be normal, definitely. There's no worries about that T-wave inversion there. AVR, everything is negative. Everything's going away from AVR, so it's all negative, that's fine. V1 is a little negative T-wave there. Yep, that's all fine, we're not worried about that. Is there any ST elevation? If you look here, it's very subtle change. Yes, even there, this little bit, but it's a very small amount of change. And of course, you should have context of the patient. There's probably a little bit of what we call early repolarization here on this ECG. And so this would really be classed as normal. Of course, it helps to have context. If you said, look at this ECG, this patient hasn't had chest pain, then you wouldn't get worried. Your eyes might be drawn to this minor change. Certainly if it's someone with chest pain, then really you think about what is the chest pain like? What's the character? Is this a chest pain that's suggestive of ischemia or even pericarditis? So you're going to make sure you do that, repeat the ECG to see if there's any ongoing changes, and to certainly do a troponin. But hopefully this is trying to signify to you that T-wave inversion lead 3, AVR and V1 is normal. Any questions? Are these hyperacute T waves? So good question, good question. I like this question as well. All your questions are good. So yeah, it's really hard to sort of say, is this hyperacute? I've shown you this ECG before. This is my ECG actually, from 6 years ago. So I'm pretty sure my potassium at the time was okay. I know it's really hard to look at this. And the difficulty is when you're a beginner, with all due respect, is you're trying to look at ECGs and look for things. But really, I probably wouldn't say this is hyperacute really, in the absence of chest pain. Not quite. I think it's normal. I think the more ECGs you see, you get used to what is abnormal and what is normal. Clearly in an exam situation, we will always give you the obvious ECG, not something that's subtle. We don't expect you to look at subtleties. So in any exam, you will have very abnormal ECGs where other people, non-specialists, non-cardiologists can pick up the abnormality as well. Okay, have a look at this one, please. Okay, so one of the ways you can do, okay, these are all STT wave changes, of course, so you can scan the leads. So go through things systematically. You can either, do the regions. So I'm going to look at the inferior wall, lateral wall, anterior wall, lateral wall. You can do that first, or you just scan the leads and just see. So you've probably got, you've got some ectopics here. These are ectopics. So remember how an ECG is recorded. The machine records 1, 2, 3 together, AVR, AVL, AVF together, V1, V2, V3 together, V4, V5, V6 together, and then it produces a long rhythm strip. So the ECGs are, the segments are taking at separate times. So in this bit, you see the ectopics, but in the rest of the ECG, you don't. So these are called ventricular ectopics. We probably have, so you've got subtle ST elevation here in those two leads. So there's the isoelectric line. The ST segment is above the isoelectric line there. But if that could be classed as early repolarization if there weren't any other ECG changes. However, AVL, yeah, that's much more of a bigger change there. The ST segment's pulled up above the isoelectric line, ST elevation. V1, clearly ST elevation. V2, ST elevation. V3, ST elevation. V4, ST elevation. Probably not V5, probably not V6. So now we're looking at the inferior wall. Look at the inferior wall now. We've got a segment that's below the isoelectric line here, below. and it's in the region, it's in 2-3 and AVF, which is the inferior wall. Okay, so again, below the isoelectric line, So that you'd be, the ECG diet, describe the abnormalities. There are ST elevation in V1 to V4, lead 1 and AVL. There is ST depression in leads 2, 3 and AVF. The diagnosis here would be an anterolateral STEMI with inferior reciprocal changes. That would get you all the marks in an exam. I don't think we'd expect the ectopics as well, but okay, any questions on that one? So this would be the left anterior descending artery, most likely. Okay, have a look at this one, please. How can you tell the difference between reciprocal changes and the actual change? So I think where you get reciprocal changes is where there is ST elevation. ST elevation is the trump. That is the thing. You can't beat ST elevation. So when you have ST elevation, that is the STEMI. The reciprocal change is on the opposite side from where the STEMI is occurring, and you will see ST depression or T wave inversion as the reciprocal change. Okay? Does that answer your question? Yeah, no worries. Good. Thank you. Okay, so this example is a bit more subtle. I've tried to put it in, and I think, whoever asked about hyperacute T waves, this is probably an example, probably. But again, you would have to have context. You could say this patient comes in with central crushing chest pain or central severe chest pain going down the left arm, and then you're heightened towards the fact, okay, I've got to look for any ST T wave changes. So, yeah. So above the isoelectric, so we've got ST elevation in lead 1. We would expect it in AVL. Yes, we do have it in AVL. Okay, so not there. Oh, we've got ST depression in lead 3. ST depression in AVF. Interesting. V1 is okay. There's a bit of artifact as it drifts down. This is probably an acute, hyperacute T wave here, and in there, and there, and there. So again, this is probably another example of an anterolateral STEMI. With ST, so it would be, the ECG would be ST elevation in V4, V5, V6, V1 and AVL, hyperacute T waves in V2 and V3, with ST depression in leads 3 and AVF. This would be an anterolateral STEMI with inferior reciprocal changes as your diagnosis. So it's a bit more subtle, and you've got to try and, it's difficult, you try and accept things. I think these are hyperacute T waves. Again, you've got the benefit of doing another ECG in a few minutes later, but you've got enough evidence here to call the STEMI team, because there is a STEMI. I suppose in an exam we might allow a lateral MI, but because V4 is the anterior wall, you've probably got an LAD territory infarct here. Okay. ECG number 4, please. Okay, so if you're scanning again, looking for ST T wave changes, there is no clinical context, but again, you'd probably say this patient's going to have cardiac sounding chest pain. Your ST elevation is in V1. Okay, so you've got it segments up, probably not very much, although this signal seems a bit more. And now you've got AVL as ST elevation very clearly. So a high lateral, would call this high lateral, with ST depression in leads 3 and AVF. That's your reciprocal change. I don't think there are any other ST elevations. So this is a high lateral. It's going to be likely to be a first branch of the diagonal. And there's another STEMI. Okay, number 5. Okay, so scanning all the ECGs, you've got ST depression in lead 1, AVR is negative, AVL has got ST depression, lead 2 has got ST elevation, so there's the isoelectric line, it's above the isoelectric line, definitely. So if we have it in 2, we should expect it in 3 in AVF as it groups together. Okay, there's ST depression in lead 3, yes, and AVF, yes. So we have inferior ST elevation. But when we go over here, we see V4R, an extra lead per ton. We have ST elevation in V4R, a right-sided lead opposite to V4R on the left. So this is likely to be a proximal right coronary artery blockage. We have ST depression in V2, V3, V4 with an ectopic beat, V5. So this ECG you would say ST elevation in leads 2, 3 in AVF and V4R. There is ST depression in 1, AVL, V2 to V5. So this would be an inferior STEMI, in brackets, proximal right coronary artery, with anterolateral anterolateral reciprocal changes. The proximal right coronary artery might come as another question. You might be asked, what is the culprit artery? The culprit artery means what is the artery that's being affected? Again, it's always one artery. Don't put more than, well, it's always one artery. Don't put more than one. But there's an example later on I'll show you. Okay. ECG number 6, please. Okay, so if you're scanning these ECGs, you're trying to look for the ST segment is okay in 1, but maybe a little bit of a T-wave inversion there. The ST segment is okay in AVL. There is definitely T-wave inversion there. You'd expect that to be together on an AVL. Lead 2 is okay. Lead 3 is okay. Lead AVF is okay. So V1 is negative, but that could be normal, but you've definitely got T-wave inversion in V2. V3, the ST segment's at the isoelectric line, V4. In particular, also, you don't have very tall R waves here. Okay, there's no clinical context. The R wave is not very tall, plus the S wave. Okay, so they don't think there's left ventricular hypertrophy here. Okay, but this is these deep T wave inversions are very suggestive of a non-STEMI in the anterolateral territory. So the ECG diagnosis would be T wave inversion in V1 to V4 or V5, and 1 in AVL. This would be an anterolateral non-STEMI. Anterolateral non-STEMI. You would be given clinical context of chest pain in this example. Okay, any questions? Okay, have a look at this example, please. Okay, in the previous one, are leads 2 and 3 T waves normal? Good question. I thought about that when I went through them. So let's just pause on this and go back. Good question. Yeah, again, your abnormality, you're good in asking the question because you need to think, is this normal? Is this not normal? I probably think these are normal, but I know what you're saying. On their own, if these T waves weren't inverted, you might have some other T waves to compare to. But I see what you mean. Yeah, are these? But what does that mean? The ST segment here is okay, and so really this is your main abnormality where the T wave is inverted. But I really do get what you're saying. I don't think they're hyperacute necessarily. And again, it's really difficult for you to see this and then see the other example where I said they were hyperacute here. You see what I mean? So you think, well, there's not much difference really. So I understand that. I understand that's difficult. But because this ECG shows this very deep T-wave inversion, that's the abnormality. This is not a reciprocal change or anything like that. It would just be, classed as normal. Okay, ECG 7 is an interesting one. No worries. So ECG 7 is an interesting one. So it's slightly fast, okay? And this is actually taken from a treadmill on a patient, actually. So this was a patient on a treadmill. You're going through the ECGs. So you got ST depression in lead 1, not really much in AVL, bit of artifact. You've got ST elevation in AVR. Okay, that might mean something here. You've got ST depression in leads 2, 3, AVF. Oh gosh, ST depression in lead V2, V3, V4, V5, and V6. You can clearly see there's the isoelectric line on these ones. The ST segment is below. You've got ST elevation in AVR. So how would you describe this ECG? So you've got ST elevation in AVR, isolated. You have ST depression in leads 1, 2, 3, AVF, V2 to V6. You've almost got global changes. So what does that mean? So if it's on a treadmill, you're looking at the increased heart rate causing a lack of blood supply to the heart. How can you affect all the ECG leads? Is it more than one artery? The only way that you can affect all the leads is to affect the left main stem. That's one artery. So you affect the left main stem before it splits into the LAD and the left circumflex. And so that can happen to patients. Or it can be a very large left anterior descending that supplies a lot of the heart and the lateral wall to get changes on the underside of the heart, to get changes in the lateral wall, the inferior wall, and the anterolateral wall. So this would be ST elevation in AVR, ST depression, consistent with a left main stem equivalent, we call it, or a left anterior descending artery, a major left anterior descending artery narrowing. So it's ST depression. This is the reciprocal change in AVR. Okay, it's the opposite. So it's ST elevation. So it's at the top right. Everything else is below that. So this is the reciprocal change. And this is your ST depression in your anterolateral inferior lateral leads. Okay, any questions? Okay, have a look at this one, please. Okay, so you're highlighted to the fact there is some clinical history, which is appropriate. Certainly you're going to think that this is going to be a STEMI. If you've looked at this ECG, you may use your basic algorithm, and the QRS is broad, and in particular it's negative in V1. It doesn't become positive till V5 and then V6. There is also left axis deviation, which fits with left bundle branch block. So left bundle branch block may be a sign that this is a left anterior descending problem because the left anterior descending supplies both the left and the right bundles. However, in this example, you do see probably super added ST elevation in V2, V3, and V4, and perhaps V5 that you probably wouldn't normally see in the presence of left bundle branch block. So I've shown you this as an example. There is anterior septal, or probably anterior lateral ST elevation, so something going up. But I've shown you the next ECG to show you. So hopefully you can see this is left bundle branch block changes, but there is ST elevation in V2 to V5. So it's going to be a left anterior descending blockage. So I've shown you this ECG before, I think, and this is another example of left bundle branch block. So when the QRS is widened, you have to accept that there is a little bit of ST elevation in the context of left bundle branch block. So there's the isoelectric line. Yes, the SE segment is above, but this is because the QRS is widened. This is another example of left bundle branch block here. Okay, so if this patient had chest pain that sounded cardiac, then this could be the ECG. Okay, there wouldn't be the marked ST elevation that you see here more than you do on the next ECG. So you can see here, this, even despite the QRS being broad, there is much more ST elevation, which you don't normally see, compared to this ECG, where there is some ST elevation, but not as marked. Can everyone see that difference that I'm trying to point to? So if we look at V2, yes, the QRS is broad, but this could be someone without chest pain. In this patient, there is much more ST elevation that you don't normally see to signify this is definitely ST elevation compared to this ECG. So the point of this is that if you see a left bundle branch block, they have chest pain that may be ischemic, you have to look at the coronary arteries. You have to look at the coronary arteries. You have to check that you can't wait for troponin. You've got to go in and look at the arteries. If the arteries are normal, then good. But if there's an LAD occlusion, then it can be opened up with PCI. For the second left bundle branch block ECG, V6 is monophasic to be left bundle branch block with the V1 negative QRS. Yes, I think I'm trying to answer your question. Second, this ECG here, V6 is monophasic. Yeah, I know what you mean. This is slight discrepant with what I tried to show you with left bundle branch block. So there is some positivity, not as positive as some of the examples I've given you, but this is still an example of left bundle branch block because it's negative in V1 like this, but it should become more positive. It may depend where the stickers are put on the chest, but you're right to point that out. Okay, so ECG number 9. So we're looking at lead 1 looks okay. AVR is negative. It's interesting. It should be negative. AVL has definitely got ST depression. We've got inferior. So leads 2, 3, and AVF have ST elevation. We have ST elevation in our lateral leads as well. So V5, V6. So you know, it is individual. It is about the individual patient that the ECGs can look slightly different. So this is what we call inferior lateral. And certainly that raises the suspicion in your head. Is this a circumflex artery? Is this a circumflex artery? So there is ST depression in V1 and V2. Is that a reciprocal change? So what you need to do is make sure is take your V7, 8, and 9 ECG and make sure that you see ST elevation. Okay, so this is a different time point in this patient where they have the inferior ST elevation. They now have V1, V2, V3 is much more depressed subsequently, and they do a 7, 8, and 9 where there is clear ST elevation in V7, 8, and 9. So this is an inferior posterolateral. So ST elevation in 2, 3, and AVF, V5 and V6, and then V7, 8, and 9 because of the previous ECG. There is possible reciprocal changes in V1, V2, V3. And so this is your inferior posterolateral STEMI. And that is definitely going to be the circumflex artery as your culprit. Any questions on that? Okay, so have a look at this ECG and then see if you can, make up a history from this ECG. So it gives you a bit of a clue. Okay, so if we go through all the ECGs, AVR is negative, which was what you expect. But we got S elevation in lead 1, it's very slight, but not too much. S elevation in AVL, again, not too much. Lead 2, not much in 3, perhaps in AVF there is. S elevation in V2, V3, V4, V5, V6. So there seems to be pretty much in every lead, apart from V1 and AVR, that there is ST elevation. It's not very marked ST elevation, it's small, but these look like what we call saddles. It's a saddle shaped. There may be PR depression here, possibly. So the PR interval goes downwards before it goes to the QRS, although that's not mandatory for there to be pericarditis. So these, you've got to think of why is there ST elevation everywhere globally? Well, the thing that covers the heart's the pericardium. If it's inflamed, you're going to get ST changes in most of the leads. So these are saddle-shaped ST elevation in association with pericarditis. Pericarditis, okay. Number 11. Sorry, I'm just going to 12, yeah. 2 more to go and then we'll do Kahoot and then we're finished. Okay, so if you go through the ECG, we're trying to look for STT wave changes. So we've got deep T wave inversion here, or we have got a very big R wave, T wave inversion there. Yeah, big R wave in AVL, T wave inversion V2, V3, V4, V5, V6. There's a big R wave, but not too much, probably in V5 and V6, sorry, the R wave in V5 and the S wave in V1 add up to probably over 35, and there is T wave inversion. This is over 12.5, clearly, and AVL plus 1 is definitely greater than 25. So each of these squares is 5, remember, 5 millimeters. So you've got here T wave inversion in the anterolateral leads associated with tall R waves in the lateral leads. And this would be an example of this is an actual ECG from someone with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, you've got T wave changes. These are the repolarization abnormalities associated with the structural heart disease, but there is evidence of very tall R waves. So it's got to be left ventricular hypertrophy here. But this pattern is particular of hypertrophic cardiomyopathy. Okay. And then lastly, again, I'm just going to give you the answer to this, another example of left ventricular hypertrophy and T wave changes. So we've got no ST elevation anyway, you've got very deep anterolateral, global almost T wave inversion. There's very likely to be possibly structural heart disease, such as hypertrophic cardiomyopathy, aortic stenosis possibly, or high blood pressure that's sustained for a long time. Again, there's a very deep S wave in V1, and a big R wave in V5, over 35 millimeters, and even in V4, you can see a very tall R wave with associated repolarization, which is T wave inversion abnormalities. So whilst you could consider that chest pain might be a feature, that a non-STEMI might be a feature, you're probably less likely to see that compared to there being repolarization or T wave changes in association with left ventricular hypertrophy. That's the difference in this ECG, that it's not really an acute coronary syndrome because there are very tall R waves. Okay, any questions? Okay. Let's go to So hopefully you should see the Kahoot. And I'll take any questions and then we're finished. I think there's about 14 ECGs. So. Okay, the first few questions are sort of on Takotsubo, great one. Basically, the first few ECGs are on sort of concepts. So 1 to 5 is on concepts. Okay, here we go. So repolarization, yeah, repolarization. Don't forget QRS is depolarization. QRS is depolarization. Okay. Very good. You do not get ST elevation as a reciprocal change in a non-STEMI, Yeah, 3 in AVF. Well done. ST depression, well done. And then the last concept question. Oh. Yeah, reciprocal. It was from the last question. Okay, well done. So okay. So what I need to do is just close it off. I'm just opening up the ECGs for you so you can see them before answering the question. Okay, so we've done the concepts 1 to 5. This is your ECG. Okay, for questions 6, 7, and 8. I'll let you have a look at that. 6, 7, and 8. Look at it very carefully. 6, 7, and 8. Six, 7, and 8. Yeah, seven. Yeah, anterolateral. Bit of a long time on that question. Yeah, well done. Okay, so let's have a look at that ECG again. So it's definitely the left anterior descending on an anterolateral. So 1, 2, 3, 4, 5, 6, 7. Okay, 7 S elevations. We've got inferior reciprocal changes of ST depression. Okay, anterolateral STEMI and left anterior descending artery. Okay, that's 6, 7, and 8. So this is your ECG for 9 and 10. What is the abnormality in that ECG? Yeah, T-wave inversion, well done. T-wave inversion is the main abnormality. Yeah, so it's a non-STEMI, It's not hypertrophy. We'll go back and look at these two. Remember, for hypertrophy, you've got to have big R waves. Okay, big R waves. You probably might have Q waves along here. So this could be an anterolateral STEMI, big T-wave inversion, okay. So there's no big R waves or big S waves in V1, V5, or 1 and AVL. They're not tall, so this is not hypertrophy. Okay. So that is an anterolateral non-STEMI, likely LAD again, but T-wave inversion, Okay, so this is question 11 and 12. I think you have a look at that, 11 and 12. Okay. 9 to 10, well done. Yeah, so pericarditis. Yeah, let's have a look at that ECG. That's probably why I asked why, there's so many leads that have got ST changes, 9 to 10 of them. The ST changes are very saddle shaped. You get S elevation and like a horse saddle if you look at it from the side. So, these are very saddle shaped. And again, to get global, 9 or 10 ECGs are showing ST elevation. You've got to think what's going to affect most of the heart is the pericardium, or most of the lead, something that's wrapping around the heart. Most of the leads are affected, inflammation in the pericardial space. And so the majority of the leads show ST elevation, which is saddle shaped. Okay, so this is pericarditis. So you've got a concept question next. And then one last question. Yep, so V1 to V3 are the surrogate leads for the posterior wall. Very good. And the last one is question 14. Question 14. Last one. Yep, so it's an inferior STEMI, 2-3 in AVF, ST elevation and 2-3 in AVF, and lateral ST depression. Okay, so that's your inferior STEMI. Okay. An apt winner for tonight is LVH. LVH, very good. An STT wave change. Okay, so any questions at all? I just need to go back to the lecture so you can see. Any questions at all? Now, I think in actual fact, just, yeah, that's, am I sharing this? Yeah. Let's have a look at this one. I think one of the questions, I think I probably, thought about this when the question was asked. So if this is just ischemia, you do have a reciprocal ST elevation change, actually. This is the only one where you will get it. So I think one person actually got that correct. And I think I might have to redo that question because I thought about it. I don't know whether the troponin was ever measured on this patient, with a treadmill, but they did have a left main stem problem. So there probably is where there's ST depression. There could be, this is the only time it will get ST elevation with ST depression in all the other leads. In all the other leads, AVR could be ST elevation. Okay, so that would be your reciprocal change in relation to the ST depression. That's the only time it happens, just to clarify that. Are there any other questions? Does anybody want to see anything again? Okay. Thank you for joining in.